everyone. It's always a bit difficult or quite challenging to have the after lunch spot, but I think Bianca and I can manage to keep you awake. I hope so. So just looking at pain, there generally used to be a feeling that pain was something that was caused by an illness or an injury, and you can see that's the International Association with the Study of Pain from '73. But as you all know, many people with spinal cord injury or any kind of central nervous system injury still complain of pain long after that cause has been managed. And I'm very grateful to Michelle Burns for her talk, because she's given a lot of what she said overlaps with what and Bianca is saying. And I'm very pleased that she introduced you to the term biopsychosocialism, because that's something that's particularly important. I've just put these slides in because I wanted to stress the fact of the trauma. Most spinal cord injuries are traumatic, and you can see the amount of damage to the cord. There's a lumbar spine that's been fixed with screws and plates. There's an exposed spinal cord, although Dr. Hodgetts showed us plenty of those. And you can see all the soft tissue injury that's associated with it. And it's that emotional aspect of the trauma and of the experience of pain that is where the thrust of our treatment can occur. Pain has a huge impact on quality of life. Again, Michelle gave us lots of lovely references to do with that. If you have pain, you can't function very well physically, move around. Obviously, your emotions are going to be down, and you do feel very depressed and anxious. If you're depressed and anxious, you don't feel like being social, you can't sleep, and your quality of life really deteriorates. So looking specifically at pain, we can term it as either nociceptive or peripheral, to do with noxious input, or central or neuropathic. And it's this neuropathic pain that tends to stay on and is difficult to manage, and that's what we're focusing on today. In the next slide, I'll come back to this one. If you can see, there is your classic idea of some sort of a noxious influence to the periphery. Those impulses, or that information, are carried up the peripheral system, modulated by the dorsal root ganglion, and then carried up the ascending tracts to the somatosensory cortex, and also the limbic system, which is the seat of your emotions. And then there is an output as well in reaction to that noxious information. I think it's terribly important to realize that pain is actually an output. You don't feel pain, you feel dangerous or harmful sensations, which are then interpreted in the brain as pain. And I like this example here. If you can imagine, I'm sure all of us have had experiences with fierce dogs, at worst being actually bitten or just being frightened by them. And if you think back to that experience, you can probably have a slightly raised heart rate, a dry mouth, pretty much how I'm feeling now. And you can associate those cognitive and emotional associations with pain. Really, the fight and flight responses are activated, and there's very much an output. So it's very much a perception. So this is called the pain mechanisms model. And if you, sorry, it's not very clear there, but if you can think that's tissue and environment. So you have things happening in the periphery, that information goes in via the peripheral nerves, goes up and is interpreted or scrutinized in the brain. And depending on your experience, your beliefs, your knowledge, your culture, your body image, your motor patterns, then there's an output, a reaction to that. So it's a continuously moving cycle of changes. So if we go back to this idea, this new term, neuroplastic pain, has been termed because of the ongoing change of it. And it's terribly important to gather that concept that the changes in the periphery that occur have a sensitizing effect on the central nervous system. And it's quite a complicated process. I'm not going to go into it here, but I would like to tell you about this book, which is developed by the Neuro-Orthopedic Institute in South Australia. David Butler and Lorimer Mosley have done a lot of work on managing chronic pain particularly, and they've developed something called the Graded Motor Imagery Program, where you grade the stimulus or grade the exposure to painful experiences. And they've had fantastic, absolutely amazing results with chronic low back pain patients, chronic regional pain syndrome, and phantom limb pain. So there's very good evidence on other populations other than spinal cord injury. But as long as you realize that emotional and cognitive aspects of the perception of pain, the lived reality of pain, then you can make changes through other treatments. Relating particularly to spinal cord injury, we classify it into three areas. Your musculoskeletal pain, which is particularly located above the level of the lesion, and it's your classic musculoskeletal pain, aching, movement-related, eased by medication. You can have visceral pain, which relates to your insides, and that very much takes on board the dysreflexia, and that's often experienced below the level of the lesion. And your neuropathic pain, which is amorphous. It's very difficult to describe. It often has a hypersensitivity or something that might just touch you that you think is just touch, but you experience that as pain, that allodynia or hyperalgesia. And those are often felt below the level of the lesion. And you might have heard it described as thalamic pain. So we conducted a very informal survey of therapists working in Perth who've either have been worked or have been working on spinal cord injury. We asked them about the details of the injuries of their population, the proportion reporting pain in the acute stage and the chronic stage, those that reported neuropathic or central type pain, the location of the lesion, and the management strategies. And as I say, this was very just anecdotal, informal survey. Again, if you think back to Michelle's presentation, she produced a lot of the results that we've used. So our results showed that in the early stage, at least 80% people complain of pain of some sort, which fits because spinal cord injury is often traumatic. 60% report chronic pain, which is very high, and 50% report neuropathic pain. So those are all very high, and I think the whole message of today is that pain is a significant a significant issue in spinal cord injury. And this data correlates with Verhagen in Sweden and Siddall in Australia, who report that between 65 and 85% of people report pain that meets that neuropathic criteria. And significantly, nearly 30% of people report they still have pain, but they've simply got used to it and manage it. Usually, pain management, you're referred to a pain team, which primarily is pharmacological treatment, which, as everyone knows, doesn't necessarily work. So it's a good idea to think of some other issues. The education, strategies to manage it. COGACT is a really important aspect, and I'm pleased that you had Michelle's talk before ours. Prevention of those secondary issues, particularly the musculoskeletal issues of shoulder pain or due to compensatory strategies that you need to use. And the cognitive approaches are really important. And because of the work of people like Butler and Mosley, who have explained very clearly the cognitive and emotional aspects to the perception of pain, that's where we can target our strategies. And that idea of biopsychosocialism, bringing in all the aspects of that impact on the pain experience, and not thinking of it as purely a biological process of where you've got an illness or something that can be fixed. So how can we do it better? We most certainly can, and I will pass on to my colleague Bianca.
Alright, so pain is a complex experience following spinal cord injury that for the health professional poses quite a challenge to treat. For lack of a better metaphor, and I apologise because I realised in rehearsal this morning how corny these next few jokes were, the multidisciplinary team need to know how to help untangle the knot that is the patient's pain experience, because essentially they've presented to that health professional because they can't figure out how to untangle it themselves. Pain isn't certainly on the list of things that a health professional is responsible for addressing. However, despite the wide variation in disability, the literature documents, and I think the audience here today can all too well appreciate how prevalent it is and how pervasive it is in its ability to create problems or magnify problems that are already present. Oh, yep, speak up. Okay, not many people usually tell me that, so that's a good thing. So based on the literature to date, as a clinician that's interested in looking at research to optimise the treatment that I provide, the neuropathic pain problem is being addressed. However, there still is some more work to do. What we do know, and what's beneficial to those working at the clinical frontline, is that when somebody presents to us with pain that has a spinal cord injury, we know that there's likely a combination of pains that are being presented. For the clinician, if you were to imagine those pains sitting as a set of Rubik cubes in that patient's lap, we know that some of the puzzles that are presented to us are more difficult to address than others. And certainly I can attest as a physio, I'd much prefer to pick up the musculoskeletal pain cube to solve, because I know I've probably got a better likelihood at a greater success rate to show off to the rest of my team and the patient. So the neuropathic pain puzzle still is very difficult to address. However, what is exciting is that there is some interest in trying to solve it beyond the pharmacological options that we have available. What is exciting for people within spinal cord injury is that we've spent a fair bit of time looking at what other research populations have been doing to investigate options for neuropathic pain. Is the voice loud enough now, or am I still talking a bit low? Bit louder? Okay, so what I was saying is what is exciting is that for a while people working in spinal cord injury or researching in spinal cord injury have been looking at what's been going in other research circles. As Ali was saying, Butler and Mosley are some researchers that have done a lot of work in chronic pain. But what's happening now, some of those researchers that have had good results in their own populations are starting to look into the spinal cord injured population and seeing whether or not the treatments that they've examined are applicable to our population. So not only are we looking over the fence, some people are looking into our fence as well. So if we're to consider the options that we have available as if they're fruits on a tree, I'm sure many people in the audience are familiar with those that extend off the pharmacological branch. There have been some surgical options, but what I'm really interested in discussing today is the rehabilitative options that we've started to consider as an effective option to treat neuropathic pain with. Some pain scientists are interested in looking at whether visual illusion is an effective treatment option to address neuropathic pain. By visual illusion, what the scientist intends to do is to try and expose the patient to a visual stimulus or client to a visual stimulus in which it appears to the individual that body parts that are affected by their spinal cord injury are moving functionally and normally. 2 studies have been specifically done in spinal cord injury. Laura Mosley conducted one in 2007, and then another group replicated that particular type of intervention in another study. The visual illusion of walking was specifically used in both studies. So Laura Mosley, an Australian professor who was working in the UK at the time, tested 3 types of treatments on a group of 5 paraplegics back in 2007. What he did is he exposed them to 3 treatments. One was visual illusion of walking. So the person was basically in front of a mirror and a projector, and the image of their upper body was projected on the top mirror whilst there was a video of walking. So it appeared as if they were walking. They were allowed to swing their arms whilst they were performing the treatment. What they also did is they did some guided imagery where they were imagining a movement, and then a third treatment is where they were watching a fairly interesting film. What they found in this study that most subjects reported an improvement or a reduction in their neuropathic pain with the visual illusion the most. And that particular type of treatment also allowed a greater duration of time to occur before the pain increased back up to the baseline. The motor imagery and watching a film did reduce the pain slightly, but not as much as the visual illusion. In 2010, a group of Spanish Spanish researchers also replicated that particular visual illusion, but they also did a trial to see whether or not adding transcranial direct current stimulation over the cerebral cortex provided an added benefit. The group that they tested it on was slightly larger and slightly more variable, as you can see. But what they found is that combined treatment of electrical stimulation of the cerebral cortex and a visual illusion also improved neuropathic pain. Either treatment alone did improve it, but only for a short period of time. Another study that was fairly contradictory was another group of researchers in New South Wales that looked at whether movement imagery, imagining a movement, had a positive impact on the neuropathic pain experience. Based on Moseley's study, they were hypothesising that they would see some positive results. However, they were surprised to see that the group of participants that reported neuropathic pain actually had worsening of their symptoms after they did the treatment. So the particular treatment involved the participant imagining themselves moving their right ankle up and down whilst they were listening to the noise of a car accelerating. So in that particular group, the majority of them found an increase in their pain intensity following that treatment. So as a clinician looking at the research and interested in seeing what treatments are most effective for the patients that we're dealing with, it is important to consider when we're looking at this particular type of research whether or not to throw the baby out with the bathwater. Something I'm particularly interested in looking at when I critique a study is the participant population that they're dealing with and comparing it to what I'm dealing with. A lot of those studies have particularly isolated their studies to the population with a thoracic injury, and I know there's certainly a larger population consisting of paraplegics and tetraplegics that need to be considered in the applicability of this research. In addition, the majority of that research has been done in people with complete spinal cord injuries and hasn't quite encompassed the full scope of severity of spinal cord injury as well. And certainly with the trends that are happening in the spinal cord injured population, there are a lot more incomplete injuries that we're seeing these days. In addition, the type of intervention that has been used, there are only a very few studies that have been done in spinal cord injury at the moment. And from my perspective, and perhaps from some people's perspective in the audience, I think this type of imagery, in a sense, rather than a physical stimulus, very much a cognitive stimulus, imagining yourself walking is probably a far more exciting experience than pretending to move your foot on and off a pedal on the accelerator. So it's important to see that some studies are providing some effective impact on pain. Some are actually causing an increase in pain. But as clinicians and researchers, can we manipulate and vary the types of interventions that we're testing before we throw these interventions away? Because they certainly are having some positive impact in other populations that have nervous system dysfunction. Transcranial direct current stimulation is also another type of intervention that falls under the rehabilitative umbrella, and it simply is providing electrical current over the scalp to stimulate neurons in the cerebral cortex. In the studies that have been done in spinal cord injury, the researchers have been specifically interested in stimulating the motor cortex of the cerebral cortex, so part of the brain more in the front end. So several studies have been done specifically in spinal cord injury where they've applied a stimulus to the cortex to see whether or not that has an impact on the pain experience for the participants they're testing on. Two studies in particular are of interest, particularly to compare to. There was a group consisting of researchers internationally that conducted a study back in 2006 on a group of participants that had their injury fairly reasonably short time ago in comparison to a study which replicated the treatment done by this earlier group, in which the average time post-injury was a lot longer. The first study found some real positive results in terms of transcranial direct current stimulation having a positive effect on the pain experience and reducing pain intensity. The Australian group, who replicated the exact treatment to a slightly different group in that this was a completely complete group and only thoracic, where the population was far more variable a lot earlier, found that there was no significant difference in the pain intensity post-treatment. Again, if you were to look at this most recent trial, you might consider that this is a treatment to throw away in the bin. However, what's an interesting thing to consider is that perhaps this is a treatment that's more beneficial quite early on post-injury as opposed to later on. Again, limited in terms of the participants that have been recruited into these studies and certainly warrants more research. Transcranial magnetic stimulation is another form of stimulation that's been applied to the same area of the brain as the direct current stimulation. However, it's different in that it's an electromagnetic current that's applied over the scalp. In addition to direct current stimulation, there have also been some positive results. However, not much research yet done to date in this specific population. So in summary, what is exciting at the moment is there is some evidence to provide support for some of these rehabilitative options in addition to the pharmacological management that's accessible to our population in WA. Given the heterogeneity within the spinal cord injured population and what research has been done to date, more work that needs to be done to incorporate the wider scope of participants so that we can ensure we're providing applicability across the board, and the types of interventions that we are testing probably need to be varied as well. So it is exciting, there is some evidence, there is more work to be done, and we are getting a fair bit of help from some other experienced researchers in this field. And thank you.